You're listening to the Psychcast by MDedge Psychiatry. And welcome into episode 157 of the Psychcast by MDedge Psychiatry, the first new episode of 2021. We hope you and yours had a happy and safe holiday and are enjoying the early parts of the 2021 new year. In episode 157, we have a masterclass lecture for you. Dr. Bradford L. Frank is discussing how he provides nursing home consultations for psychiatrists. He references specific documents. Those documents are available in the show notes. So if you go to notes, wherever notes are found in your particular podcast app, they will be available there. There are links as well as more information about Dr. Frank and the topics discussed, courtesy of Dr. Jacqueline Posada. Okay, without any further ado, let's get right to the lecture. Please welcome Dr. Bradford Frank.
Hello, I'm Dr. Bradford Frank, Clinical Assistant Professor of Psychiatry and Behavioral Science, Department of Psychiatry, University of North Dakota, School of Medicine and Health Sciences, based in Grand Forks, North Dakota, and also a staff psychiatrist at Rural Psychiatry Associates, also based out of Grand Forks, North Dakota. Today I'm going to be talking about what you need to do in conducting psychiatric consultations in nursing homes. Just to give you a little background about myself, I've been a full-time psychiatrist for about 40 years. I've been focused on doing consultations in nursing homes over the last 5 or so years, increasing the time. And now I do this almost exclusively. I currently attend about 30 nursing homes in North Dakota. I'm also board certified in geriatric psychiatry, so we have a lot to discuss, so let's get to it. So when you go to do a psychiatric consultation, typically the company that I works for, Rural Psychiatry Associates, sends some documents to the nursing home before the consultation is done. And part of that is a sheet asking for information about the patient. And of course, like any consultation, you want to have a past psychiatric history, drug and alcohol history, any prior psychiatric hospitalizations, suicide attempts, family psychiatric history, and then something that I'm kind of peculiar or something that it seems to interest me more than most my peers is their social history, including marital history, how many sons and daughters they have, their educational history, where they were born and raised, their work history, and their heritage, so that can be included, obviously, in the evaluation that you produce. Also, any military history or legal history. So all of that should be available when you start the consultation. Then when you talk to the nurse, obviously they're going to present the information about why they want the consultation. And as they're doing that, I start to build a diagnostic list on the sheet that I use to collect all this information. And I should say that I would be happy to have this document and other documents that I will refer to during the presentation available to you at MDedge Psychiatry on their website. And so if you're interested in those, you can just download them, and that'll make some of the stuff that I'm talking about today much easier to digest rather than trying to write it all down. So we begin to build the diagnostic list, and we'll talk about the diagnoses a little bit later in the presentation, but let's just kind of go through the information that you're gathering. And like you're doing this yourself, you're going to be getting the information that I mentioned, and then also you're going to be, as you do the documentation, presumably an electronic health record, you're going to be writing down the different problems. One of the things that we have found very handy is using documentation examples from the DSM-5 that are listed in one of these documents that I just referred to, and we cut and paste that and put that in the patient's chart so that you don't have to kind of redo that for every patient that you see. And that makes it much easier to do these evaluations. So again, those documentation examples I'll be referring to several times during the presentation. Very, very useful and important in doing consultations in nursing homes. So begin to build the diagnostic list, obviously getting the patient's list of medications and talking to the staff about, what you're going to be doing. Going through the medical history, we want to record all that in the chart, and any prior medications that I mentioned previously. Uh, and then doing the impression, which will, again, the impression is, for example, Carlos presents with psychosis, depression, and what appears to be mild Alzheimer's disease. He has improved on his sertraline. He has metastatic cancer and is now on comfort cares. Needless to say, his prognosis is poor. In this impression is where a lot of the information from those documentation examples would go, such as if they're on an antipsychotic medication, if they're on multiple medications for the same purpose, then you want to include that documentation. And also for gradual dose reductions, the documentation for that is very important, and that's verbiage right out of the Centers for Medicare and Medicaid Services. So all of that documentation can be picked off the documentation examples and put back in the chart. One of the things that's peculiar to nursing homes is like the mini mental status exam, which is called the BIMS, brief interview for mental status. And let me go over that slightly because this is mandated by, so it's a 15-item document, and nursing staff completes this, and then they give you the score. 13 to 15 means they're cognitively intact. 8 to 12, moderately impaired, and below that, severe impairment. So I just note that at 12, which doesn't seem very low, they already have moderate impairment, not mild impairment, but moderate impairment. It's also possible with the BIMS score of 15 on more detailed neuropsychological evaluation to find out that the patient actually has moderate dementia. So keep that in mind, that you can't just rely on the BIMS score. Also note that if they are unable to do the test, the score is 99, not 0. It's just the way that it's scored. Nursing homes also do the PHQ-9, Patient Health Questionnaire, 9 for depression. In the evaluations that you do, you want to make sure that you're getting labs just like you would do in the clinic. Also, I just want to mention a few random things that come to mind. It's complex trying to describe all of this in a brief time, but Medicare and Medicaid services sort of prohibits the use of Benadryl and hydroxyzine for the use of treatment for anxiety, just to keep that in mind. They're also not keen on olanzapine because it's highly anticholinergic, although I must say that in our practice, we do use quite a bit of olanzapine, even though they don't like that very much. So let's talk about gradual dose reductions. Again, this is a very important thing in nursing homes. Mandated by the federal government every so often, per a certain schedule, depending on the medication for all psychotropic medications. Staff have to try to reduce the dose of these medications. So this has to be done in conjunction with the staff, talking with the staff, deciding whether you want to go along with the recommended gradual dose reduction, GDR, or not. If not, then staff has to write down, typically on a form generated by a consulting pharmacist, about the reasons why you don't want to do the GDR, and then you also have to document this in the record. State reviewers that come in are typically looking for gradual dose reduction and to see whether or not you're compliant with that. This is a very big deal. Nursing homes can get deficiencies if you're not doing that. Let's talk about the use of antipsychotic medications. There are, of course, black box warnings saying that these medications should not be used in elderly patients. Probably you're all aware of that. However, these medications are, of course, often used. So let's go over the particulars. CMS says that you should not, they specifically say that you should not use these medications for restlessness, patients that are uncooperative or wandering. I mean, that's specific language that they say. So when you're prescribing a medication, an antipsychotic medication, you don't want to, in your documentation, say this is for agitation or this is for dementia. You know, that's what reviewers are looking for. So you want to make sure that if you're using a medication, except under extreme circumstances, that the patient actually has psychotic symptoms. Now, staff don't know oftentimes what you mean by psychotic symptoms. So hallucinations and delusions, and of course you have to explain to them what are delusions, false beliefs. And the staff will say, no, they don't have any of that. If you keep sort of pinning them down, then eventually they'll say, oh, yeah, they do believe that their mother is still alive and they're 93, or that their husband is visiting and, you know, their husband's been dead for a long time. So for most patients, you can eventually get out of the staff the fact that the patient does have psychotic symptoms, and then you're going to list that as a diagnosis, and that gives you a reason to use antipsychotic medications. Just to say what the American Psychiatric Association says in light of the black box warning about use of antipsychotic medications, their guideline recommends when delusions and hallucinations are severe, dangerous, or distressing to the patient with dementia-related psychosis, these symptoms need to be evaluated for medical illness related and or iatrogenic causes and then treated. Okay, so even the APA realizes that we have to use these medications. Nursing homes has what is called the 5-star quality measures. And these are just like you see on Amazon or you know, other rating areas where they have 5 stars. Nursing homes also have this. The use of antipsychotic medications, the more antipsychotic medications you use, the lower the 5-star ratings. So nursing homes don't like that. The only exceptions to this are schizophrenia, Tourette's syndrome, and Huntington's disorders, where the use of antipsychotic medications don't get tallied sort of against the nursing home. Apart from that, they do. And so nursing homes don't like it when you use these medications. You just have to keep that in mind. They're used a lot. Let me jump to using PRN medications in the nursing homes. There are sort of 2 types. One are the use of antipsychotic medications, PRN medications, which can only be used for 14 days. After the 14-day period, you have to reassess the patient, and this actually has to be done physically. Many nursing homes don't know this, but you do. So the primary care provider needs to reassess the patient so that the use of the PRN antipsychotic medication could be extended for another 14 days. If it's some other PRN, such as a benzodiazepine, after the initial 14-day period and without a physical examination, that PRN could be rescheduled for an indeterminate amount of time. You just have to specify what it is. For example, 14 days, 30 days, 60 days, whatever you specify. Non-standard medications that could be used, I'll just list a couple. You know, the nursing home says, well, you know, they're not taking oral medications and they're agitated. What are you going to use? Try to stay away from Haldol or first generation antipsychotics because according to a recent CMA that I attended by Dr. Henry Nasrallah, drugs like Haldol actually cause brain damage and so shouldn't be used. If push comes to shove and you have to use it, you know, so be it. But otherwise, you would want to use something like Zyprexa. You can also use Abilify, which comes in a liquid. And then, of course, you could use long-acting injectables like Invega or Risperdal. We also use Seroquel gel, which has to be compounded and is expensive, but we found that to be quite effective for patients that are refusing oral medications. Benzodiazepines, Ativan, of course, comes IM and also comes in a liquid. Antidepressants, Celexa and Prozac come in liquids. So I just wanted to mention those in case the patient is refusing oral medications. Let's move on to the diagnosis of the different types of dementia. If you look in the DSM-5, of course, they're all listed. but with a special mention to multiple etiologies. A recent study in 2018 by researchers at Rush University found that on autopsy of 1,000 patients, 78% had two different kinds of dementia at least. So really, when we say the most common type of dementia is Alzheimer's, the most common type of dementia is probably a combination of Alzheimer's and vascular dementia, just something to keep in mind. So I do see patients that come into the nursing home, they come with the diagnosis of vascular dementia, which requires that they either have an imaging study showing that they've had a stroke or some other vascular problem, or they've had a stroke. And when you ask the staff about this, they say, no, they haven't had those things. They have a diagnosis of vascular dementia, but then they're on medications that are only approved for Alzheimer's, such as Aricept and Namenda. So typically what I do in that situation is I change the diagnosis to multiple etiologies, and then I put in parentheses Alzheimer's plus vascular, and then I add the severity. All of you are, I'm sure, familiar with the pathology of Alzheimer's, so I'm not going to talk about that. I'll mention the treatment of Alzheimer's. If you use Hippocrates, which most people do, the treatments for Alzheimer's or any dementia are not listed under psychiatry, but they're listed under neurology. And so I would encourage you to go there under neurology, look at the doses and indications for donepezil, memantine, which is Namenda, and rivastigmine, which is both for Alzheimer's and Parkinson's dementia. If a patient has Parkinson's dementia, you want to use rivastigmine, not donepezil or Namenda. Let me now jump to one of the problems in treating patients with dementia is, of course, agitation, and that's probably the most common reason why psychiatrists get consulted in nursing homes is for agitation. I've looked through the literature multiple times, and the treatments are not very good. If they have psychotic symptoms, then of course you can use antipsychotic medications. The drugs that we would use under those circumstances would be Risperdal, Abilify, Seroquel, and Rexulti or brexpiprazole, which is now my favorite because at a 2 milligram dose, it goes up to 4 milligrams, but at 2 milligrams, it's been found to be effective for agitation related to dementia. It, of course, is not perfect like all medications. Some patients can't take it. Some have side effects. Some insurances don't cover it. Also, in using Risperdal, it should not be used in patients that have Parkinson's disease because it causes the most EPS. Under those circumstances, you would want to use Seroquel or one of the others that I'd mentioned. Also, a possibility would be Clozaril. Let me just say one thing about diagnosing Alzheimer's versus vascular dementia. In making this diagnosis, when you diagnose Alzheimer's disease, you do not need an imaging study. It's a clinical diagnosis. Even if you look in the DSM-5 diagnostic criteria, they do not mention imaging. If you do happen to get imaging and an MRI, it can be somewhat confusing about whether or not the diagnosis is most consistent with Alzheimer's or vascular. So just let me clarify that one point. If you see white matter hyperintensities on the T2 weighted MRI, that can be seen actually in normal patients, that is, say, patients without dementia. There are more white matter hyperintensities found in Alzheimer's disease, and still more found, obviously, in vascular dementia. Same thing for microinfarcts. So you have to look at the overall severity of the white matter intensities and microinfarcts to help you ascertain, is this Alzheimer's and vascular dementia, or primarily vascular dementia. I'm not really going to talk about Lewy body dementia and the other dementias. You can read up on them in the DSM-5. Don't really have time to go over those, except to say that to make the diagnosis of vascular dementia, as I mentioned, they either have to have had a stroke or imaging consistent with vascular disease. For a diagnosis of Parkinson's dementia, they have to have Parkinson's disease first. Another diagnosis that we sometimes see that's not mentioned in the DSM-5 I'll mention is progressive supranuclear palsy, PSP. And this is what I see as sort of a severe Parkinsonian type of patient with dementia, uh, which is pretty rapidly progressive. So sometimes you see that, you can read up on that, PSP, progressive supranuclear palsy. So let me go back and just say a couple words about the treatment of agitation, which I started talking about, and then I talked about the antipsychotic medication and skipped over a couple of things. The number one treatment that geriatric psychiatrists use is citalopram. And if it's a 90-year-old patient, you're going to start with 5 milligrams and then work your way up to a maximum of 20 milligrams in patients that are 60 years or older. And just to say, escitalopram, Lexapro can only be used up to 10 milligrams in patients that are over 60 years. But citalopram is the medications that's used most and talked about most and is most in the literature for agitation associated with Alzheimer's dementia and other dementias. I can tell you that the studies supporting that are not very good. One study that said that it works used a dose of 30 milligrams. So studies are really not very good, but it's the medications that is used first that should be tried first. A couple of other kind of weird medications that are supported in the literature are Nuedexta, used for pseudobulbar affect, and Nuplazid, pimavanserin, which is of course used for psychosis related to Parkinson's disease. Both of those show some benefit, especially Nuedexta for agitation associated with Alzheimer's disease. The problem with using these medications is their insurance is likely not going to pay for them. And so you're again left with citalopram and the other antipsychotic medications or benzodiazepines. A quick word on the use of benzodiazepines. Of course, the first thing I want to ask the staff when they say the patient's agitated, can we give them Ativan? My first question is the patient taking opioids? If so, then I don't really want to use Ativan or other benzodiazepines if that can be avoided. Okay, so let me jump to diagnoses. Now, there's a couple of important things to mention about diagnoses in the nursing home. And you can write these down because those are not on the documents that are going to be available. Nursing homes get paid more if you use these diagnoses. Our job is not to ensure that nursing homes get paid more. We don't get paid more if we use these diagnoses, but I think it's our fiduciary responsibility to list these diagnoses. And I actually also find them very helpful in the diagnostic list. When I see a patient that I haven't seen before, if they are listed, then I have a good idea of what's going on with the patient. So the patient is agitated. Okay, so they get a diagnosis of restlessness and agitation, R45.1. Noncompliance, Z91.19. Wandering, V40.31. Now, for dementia, we don't use DSM-5 diagnoses because nursing homes are using ICD-10 codes, which complicates matter. So let me give you the ICD-10 codes for dementia. And this means that, we diagnose dementia with or without behavioral disturbance. Okay, not Alzheimer's disease. And in the computer program that we use, which is Advanced MD, the options for with or without behavioral disturbance are not listed for Alzheimer's disease. For nursing homes, it's very important if the diagnosis is with or without behavioral disturbance. So the diagnoses that I use are dementia, let's say with behavioral disturbance, F02.81. If it's dementia with the behavioral disturbance, vascular, it's FO2.51. You could, sort of play around with these in your own electronic medical record. If they don't have behavioral disturbance and they have Alzheimer's dementia, it's F02.80. And if they have dementia without behavioral disturbance, vascular, F01.10. 6.50. Recently, we found the only diagnosis that you can, in the ICD-10, that you can use that's appropriate. Lots of patients have dementia. They don't have schizophrenia. They don't have bipolar disorder. They don't have schizoaffective disorder. They don't have delusional disorder, but they're psychotic. So what do they have? They may have delirium, which is a diagnosis that I try to stay away from because it's ephemeral. It comes and goes. You have to list it. You have to unlist it. The diagnosis that we use now for psychosis with delusions is F06.2. That's psychotic disorder with delusions due to a known physiologic condition. F06.0 is psychotic disorder with hallucinations due to a known physiologic conditions. Very helpful in trying to figure out what diagnoses to use. And I must tell you that the powers that be, the government and various regulatory agencies, don't like psychiatrists using unspecified. Unspecified depression, unspecified anxiety, unspecified dementia. They want us to be specific. They figure if you're a psychiatrist, you have enough knowledge and experience to actually figure out what the diagnosis is. So try to stay away from unspecified. I also have a couple of documents that will be available to you on the website that I listed, and those documents include a list of anticholinergic medications, our first line, and like that. So I'm sure I've left out a few points. It's a complicated area, but I hope that I've hit on things that you will find helpful.
And that's a wrap on episode 157 of the Psychcast by MDedge. The Psychcast is produced by MDedge editors Gina Henderson and Jeff Bauer. All of our podcasts are produced by executive editor Kathy Skarbeck. The show notes are authored by Dr. Jacqueline Posada, and our guest lecturer this week was Dr. Bradford Frank.